Hello, everyone. Good afternoon. Welcome to the webinar here. We're going to start, and I will pass it over to Mr. Timothy Egan.
Thank you, David, and good afternoon or good morning, depending on where you're calling in from, ladies and gentlemen, and welcome to this COVID-19 information webinar on exposure notification, testing, and reflections on today and what the future holds. I'm Timothy Egan. I'm President and CEO of the Canadian Gas Association. We're the National Association for Natural Gas Delivery in Canada, and we're happy to have the opportunity to have this webinar with you today. I'm going to briefly introduce our panelists, and then I'll set the stage a bit and tell you a little bit about CGA and why we're doing this. So first, our presenters for this webinar are representing a variety of different sectors who are tracking the COVID-19 situation. First, we have on exposure notification, Lucie Vignola, who's the Director General of COVID-19 Communications at Health Canada, and Chelsea Novak, who's Head of Outreach in the Canadian Digital Service, both with the Government of Canada. Then we're going to turn to talk a bit about COVID-19 testing, and we have Dr. Paul Lem, who's Founder and Chief Medical Officer with Spartan Bioscience. And our third presentation will come from Dr. David Naylor, addressing immunity and antibodies, but also the current situation and what the future holds. And Dr. Naylor is co-chair of the COVID-19 Immunity Task Force, Professor of Medicine, and President Emeritus at the University of Toronto. We're going to have presentations from the three. I'll kick off a Q&A with some initial questions to each of our presenters, and then we're going to open the floor, and there's an opportunity all of you have as participants. You'll see on the right of your screen a mechanism whereby you can write in questions, and we will review those and try to get as many of those answered as possible. And we've got an hour and a half. We're going to 2:30 Eastern time on this one. So with that, why don't I tell you a little bit about CGA and where we're coming from. So again, as I noted, the CGA, the Canadian Gas Association, is the National Association for Natural Gas Delivery in Canada. So we're the utilities that are moving natural gas into homes and businesses and industries across the country. We serve more than 2/3 of Canadians. Natural gas meets roughly 35% of Canada's end-use energy needs, which is significantly more than electricity and is the fastest growing source of energy in Canada. Now, what we do is we put a gas into people's homes and businesses, so safety and security is a primary concern for us at all times. Needless to say, that has been a very useful priority for us in light of the COVID-19 pandemic. And a key part of our response on that pandemic has been led by one of our task groups, our task group on, and I'll just jump to the next slide if we can. Our task group on our committee on health and safety. It's one of the foundational committees of the association. It's made up of representatives of the gas utilities right across the country, and its mandate is to continuously improve safety and strive for enhanced and broadened industry drive to total worker, public, and process safety. So we're talking about safety for our own workers, for the public we serve, and for the process that we're managing in the delivery of natural gas to homes and businesses. We have initiatives in a variety of different areas listed there on the screen in front of you, but one of them is pandemic information sharing and response. We've had pandemic protocols in place for many years in response to earlier pandemic situations, and we were able to engage those very quickly with the start of the COVID-19 pandemic and have had them in place. So we as an industry have been working very closely with public authorities and others over the course of the last, what is it now? We all remember back to mid-March when this started, and have been maintaining our active engagement on the file ever since. So part of that active engagement is to try to make sure that we're staying as abreast as possible of current information that's relevant to the discussion on COVID. And that's why we're delighted to have the opportunity today to have presentations from this excellent group of people who will be about to speak. And so without further ado, I'm going to turn it over to Lucie Vignola and Chelsea Novak, who will give us our first presentation. Lucie.
Hi, thank you very much. Happy to be here. Back in June, the Prime Minister had announced that we would be launching an exposure notification app for all of Canada. And so on July 31st, we were happy to make that happen. So it was a real labor of love between the folks at CDS and folks at Health Canada and others. And we worked very closely with Ontario as they were the lead province that was moving forward with this. And we worked closely with them for several weeks to make sure that we were coordinating our communications and advertising efforts in order to be ready to go on July 31st. So in terms of the communications efforts, radio ads started on July 31st and print as well in the National Post and Globe and Mail and Toronto Stars and local outlets as well. There's been extensive stakeholder outreach throughout various organizations, so that will continue as we keep talking to additional provinces to sign up and join us on COVID Alert. So those conversations are happening right now, and we'll be in a position to keep announcing provinces over the coming weeks as they sign up, which will make it so that it'll be a more useful tool for Canadians across the board. To give you a little bit of an idea, in just over a week and a half, we've got 1.8 million downloads of the app so far. And so that's mostly based on people's phone usage, mostly on iPhones, but Androids are in there as well. We've got a 4.8 star ranking in the Apple Store, which is excellent, and we're getting a lot of great coverage there too. The Privacy Commissioner has been vocal about saying that this is a good app, and it's one that he is very comfortable with, having worked with the Chief Digital Office and ourselves to create this. And our search engine marketing is showing a 43% click-through rate, which is quite excellent and way above the stratosphere, what typically happens on Government of Canada campaigns. So that's just a tiny little sample of what we've got going on there. Just to give you a bit of an idea, and this will be happening in the other provinces and territories as they sign up, we made sure to coordinate our advertising and marketing efforts with Ontario. So in places where they were already in market, we weren't looking to double up. We were looking to make sure that we had extra pairs of eyes elsewhere where they weren't. And so that's been a lot of the focus that we've been doing there. Twitter, we've had over 2.3 million impressions and click-throughs to the web. Our most popular tweets are all around helping to limit the spread and double your protection, because that's what this is at the end of the day. It's before you leave your house, remember to take some hand sanitizer with you, bring your mask, and make sure that you've downloaded the app. And with that, I'll hand things over to Chelsea, because I'm sure you've all already downloaded the app on your phones. But in case you haven't, she can give you a quick walkthrough of what it looks like. So Chelsea?
All right, thank you, Lucie. Okay, so I'm from the Canadian Digital Service, and we are the group that built COVID Alert, which is Canada's national COVID-19 exposure notification application. So I'm going to be doing this demo on an iPhone. However, as Lucie pointed out, the app is available for Android and phones as well. Before I begin, I'd like to remind us all how we got here. So Apple and Google developed an exposure notification framework, basically adding technology to your operating system, which makes it possible for governments to create apps that can help slow the spread of COVID-19. A group of Shopify volunteers started developing an app for a single jurisdiction called COVID Shield, which the Canadian Digital Service has modified and completed with the help of Shopify, the Ontario Digital Service, and others to create COVID Alert. This app supports multiple regions and languages and interfaces with the national server and healthcare portal that we also built. So I'm going to take you through the experience for a first-time user of the app. Imagine that you've seen some of the great marketing that Lucie was just talking about, and you've gone to the Apple App Store or the Google Play Store, And you've downloaded this app, we're ready to go. So I'm going to tap on the icon. I'm going to choose English. And right away, we were finding out why we're doing this. Together, we're helping to stop the spread. It helps us break the cycle and lets people know if possible exposures before they can appear. This is the 1 through 6 step process is what every first-time user sees on the phone. Then we get right into what the app does and does not do. We know that a lot of people may hesitate to install the app on their phone because they have privacy concerns. So we know that trust is an issue, and we want to start immediately by letting people know that this is private. The app has no way of knowing location, does not use GPS, it doesn't know your name or address, your phone's contacts, your health information, or the health information of anyone that you're near. And then how does it work? It uses Bluetooth to exchange random codes with nearby phones. Every day, it checks a list of random codes from people who tell the app they've tested positive. If you've had close contact with one of those people in the last 14 days, you'll get a notification. We also remind people that it is one part of public health. Just like Lucy mentioned, wearing your mask, washing your hands, using hand sanitizer, practicing social distancing. This is one other tool that you can have in the toolkit to help stop the spread. It also reminds people that this does not replace medical advice. So you need to follow all the public health guidelines in your area. And if you get sick, contact a doctor or healthcare provider. Another way to reinforce the privacy and control of this app is that the app doesn't ever do anything without asking your permission first. And so the user always knows that they are in control. So before they're about to take any action, it will ask your permission. And at the same time, we invite people to learn about their privacy and go through their privacy policy. This was written in simple and clear language so that anyone can understand it. So I recommend it if you don't have the app already, have a look it through. And so now it's going to ask me to enable exposure logging and notifications. So I'm going to enable. The next step of starting the app for the first time is choosing your province or territory. This is optional, but there's a couple of reasons why the app wants to know this. First of all, not all regions will be participating when the application goes live. We want to provide guidance based on whether or not it's available in your province or territory. Second, the application can give specific advice from a provincial or territorial health authority when you receive an exposure notification. So what the guidance is in Saskatchewan may be different than what it is in Nova Scotia. For this, we'll start in Ontario because that's the one that is currently live. And now the app is just asking me to send me notifications, which means that if I have been exposed, it can actually send a pop-up to my phone. So I have notifications set. I go back to the main screen. What do? Nothing. Carry on with my life. This app runs in the background on my phone. If my phone and I are closer than 2 meters away for 15 minutes or longer with someone else on their phone, which has COVID alert installed, the phones will exchange random codes via Bluetooth. I go about my day. The phone collects random codes of all the other phones I've been near. It doesn't upload or transmit them anywhere. It only stores these on my phone itself. Also, throughout the day, the phone will download from the national server the random codes of all the phones whose users have reported testing positive through the app. If any of those codes match a phone that I've been near in the 14 days, and that matching takes place on the phone, not on the server, the app will notify me. And I'll show you what that looks like in just a moment. But from my perspective, there's nothing I need to do. I don't need to open the application again unless I'm diagnosed with COVID-19 or that I'm notified that I've been exposed. Before I show you those scenarios, let's see what it looks like in provinces that aren't yet on board. So I'm going to change to Manitoba. I get no reporting in your area. So that means that the app is not active in my province. However, we're still encouraged to turn it on. It's particularly useful in regions where a metro area crosses a provincial or territorial boundary, such as Ottawa-Gatineau, or where there's a concentration of provinces close together, say like the Maritimes. If a person in a non-active region has the app installed, they can still be notified if they're potentially exposed to someone in an active region who's using the application that they were near. As more and more people start traveling, this becomes even more useful. The app is fully bilingual. It can switch to French at any time, but it will download in the setting that my phone is on. So I'm going to switch back to Ontario and finish the demo. Okay, so let's talk what happens when I've been diagnosed. If I'm in a province or territory that's been included in COVID alert, it means that when I receive a positive test result from my local health authorities, I'm given a one-time key. Entering that one-time key into the app lets my phone notify people that I've been close to in the last 2 weeks that they may have been exposed. So let's do that. I'm going to press enter your one-time key. And again, keeping with the tradition of informing people what's to come, we let people know the 3 steps that they're going to be asked to do. They're going to be asked to enter their code, one-time key. They're going to be asked to agree to let COVID alerts share, let people know they were exposed, and then asked for the phone to share random codes. And we remind people, nobody will get any information about you or the time that you were near them. We know that there's a lot of intense feelings when people are diagnosed with COVID-19 and a lot of anxiety they may have about letting people know that they may have been exposed. This is anonymous. It doesn't let people know who they may have been exposed, just that they may have been exposed. I'm going to press next. And I happen to have a demo one-time key. And I submit it. It's accepted, and so now I can upload my code. So basically the phone is asking my permission to upload any random codes of basically those people I've been around for the last 14 days. Nobody will get any information about me or the time I was near them, and I can help slow the spread. So I'm going to agree. I'm going to share my codes. This is just a server thing, not to worry. And then I get thank you for helping to slow the spread. And then I'll be asked every day to upload any codes that I may have generated from this point moving forward. So let's talk about what it looks like for people who have been exposed. I'm using a demo version, so I'm able to do a neat little trick here. And this is what I get. So again, odds are pretty low of me getting a live notification, and this is a demo. So this is what it looks like if I've been exposed. It says basically I get instructions on what to do next. Because I'm in Ontario, I will get sent to the Ontario testing site, and I'm not at risk of being affected. So that is our demo of COVID Alert, and I hope that was helpful.
That was very helpful. I want to know how many of us were walking through that with you as you were doing it.
The best onboarding you could get.
Absolutely, absolutely. That was a useful walkthrough. Thank you, Lucy and Chelsea, for that. Next, we'll go to Dr. Paul Lem, and Paul's going to talk to us about COVID-19 testing. Paul?
Thanks, Tim. Hi, everyone. Fire up my slides. The first thing I want to mention is when it comes to COVID-19 testing, I think this quote is very appropriate, where you can never have your cake and eat it too. You get to choose, is it going to be cheap, accurate, fast? You can get two. This is from Dr. Jeffrey Baird. He's a top infectious disease person who runs a COVID testing lab. So what I want to do in this presentation is go over the 3 major types of testing. And so at the end of it, you'll have a good idea of what your choices are. In terms of testing, there's 3 major types of things you can test for. So the first 2 are things to do with the virus. The last thing is to do with the human response to the virus. So for COVID-19, the actual virus is called SARS-CoV-2. And so you can either test for the virus genetic material, which is the viral RNA. You can test for the proteins that make up the virus, that's virus antigen. Or you can test for the human body's response to being infected by the COVID-19 virus. So that's the antibodies that people make in response to infection. Let's go through each of the testing targets one at a time and look at some of the commercial ways of testing for these things. So let's start off with what's called reverse transcription PCR. So this is a Nobel Prize winning chemistry PCR that is excellent at detecting genetic material. And this is the gold standard for detecting COVID-19 infections. A lot of people say it has an accuracy rate probably in the 98% range. So this is what, for example, the CDC uses, Public Health Ontario, National Microbiology Lab. This is the gold standard. And in terms of this RT-PCR testing, you have 2 choices. So one is a lab-based test. So this is where you collect that nasopharyngeal swab, you ship the swab off to a big lab, perhaps in downtown Toronto. It's run on a big mainframe DNA analyzer. For example, this is one by a company called Hologic. It's their Panther system. Like they can run 400 or 800 samples every few hours. And this is the backbone, especially in the United States. The advantage here, processes lots of samples at a time. It's highly accurate. The disadvantage are it's more expensive, and you also have to wait to ship your swab to that central lab where they process it all together and then send the results back. Then there are these what are called point of care RT-PCR devices. So this is a company out of California called Cepheid. They make this gene expert system about the size of a toaster. So this gives you one sample at a time, gives you results in less than an hour. So this is fast, it's accurate, but it's not cheap. And in Canada, so we're a Canadian company, Spartan Bioscience. That's our device there. It's a portable DNA analyzer about the size of a coffee cup. And in April, we got Health Canada approval for our COVID-19 test. Subsequently, in May, we had to do a voluntary recall because it turned out our swab, we were trying to swab the front of the nose and the back of the throat, just doesn't collect enough virus material. So for the last 12 weeks, we've been working on doing experiments to solve the swab issue. I think we have, and now we're going to be submitting back to Health Canada to run a clinical study and then resubmit for Health Canada approval for our test. I think the good thing, the fact that we're in Canada, is we have that ability to be the domestic supplier of portable COVID-19 tests. What we've observed and heard from our customers is our competitors in the rest of the world, for example, the United States and Europe, they are trying to keep their supply in their home countries. And so as far as I know, we're Canada's only portable DNA analyzer company. And hopefully soon we'll have our portable COVID-19 test back on the market. Similar to Cepheid's test, we are fast and accurate, but not as expensive as the next two testing methods I'll talk about. So moving on to antigen tests. So this is looking at the proteins that comprise the virus. And different experts say that these antigen tests as a testing methodology, probably in the 50 to 90% accuracy range. So one of the problems with antigen tests is you need a lot of antigen before the test will pick it up. A second major problem is a lot of the virus antigens goes down as the body ramps up antibodies. So the FDA, for example, on a lot of the antigen tests that have been approved in the United States, they say after about 7 days of symptoms, you're at higher risk of these false negative results where, because the antibody response in the body is fighting the virus, you can't see the antigen as well anymore. This is an example of a popular antigen test. This is a point of care device made by a company called Quidel. And it is fast, it's relatively cheap, but it's not that accurate relative to the RT-PCR type test. Finally, on to the third type of testing. So this is testing for the body's response to COVID-19. So this is when your body creates those antibodies to fight the virus. So this is a fast test, is relatively cheap. The big problem again is accuracy. It takes time for the body to mount an immune response to the virus. So a lot of experts say it's not until the second week of symptoms that you can really detect it. So in general, antibody tests are not used that much for diagnostic testing. It's more used for testing the population to see what percentage of people have actually been infected by COVID-19. So in summary, you have your choices for diagnostic testing. It's really the RT-PCR type test that look at the viral RNA material, or you have the antigen tests that look at the proteins in the virus. And then a non-diagnostic test would be these antibody tests that look at the population to see who's developed antibodies and who's previously been infected. And just to summarize, so this is that antibody test where you take a drop of blood, you put it on that strip, kind of the same technology as home pregnancy tests. And that's the end of my presentation. Tim, I'll turn it back to you.
Thank you, Paul. Fast, accurate, and cheap. I'm writing this down as we think about ongoing messaging for our industry and what we do. Sounds like you're getting there with your own company. Lots of questions come to mind there, but before we go to questions, I'm going to go to Dr. Naylor. David, over to you.
Thanks very much, Tim. I'm delighted to be here as part of the panel. Let me just make sure this is shared. There we are. The topic I was asked to address was not only this question of immunity, but also a little bit of reflection on where we are and where we might be going, because I think there's a bit of anxiety heading into the fall. First, by way of background, I had the good fortune to work with a remarkable group of public health and infectious disease specialists and others after the 2003 SARS outbreak, and to take a look at how things went and think about better machinery to respond. And 17 years later, one thing I can tell you is this is not SARS-CoV-1 or SARS-1. This is a very different outbreak. For many years, infectious disease specialists and epidemiologists have been worrying about what they call the big one. This is the big one. It is a pandemic. It's really remarkable in scale and has had a pretty devastating impact in many countries. By way of comparison, if you think of SARS, the 2003 version of a very pathogenic coronavirus, we had about 9,000 people infected that we know of worldwide, probably a little more than that because some were undetected. However, death toll perhaps was higher than it now looks as though this will be, running 9 to 10%. Nonetheless, that's the total number infected, and much, much lower. Whereas here we have 20 million people infected worldwide that we know about, 120,000 in Canada, and we're closing in on 9,000 deaths versus 44 from SARS in the earlier version that broke out in 2003 and hit only a limited number of regions. So a very different virus, in notwithstanding all the similarities in structure, in receptor attack. This is more insidious, it's more infectious. You have larger numbers of people who are asymptomatic or a very mild disease and who can spread the virus without being aware of it. You have pre-symptomatic spread, which is a real challenge. So all in all, a big handful for us all to deal with. I would add that we also have this worrisome phenomenon of long haulers. That's people who continue to have symptoms despite having recovered from the acute phase of the virus. So many concerns here. Today, of course, we see the big peak has receded a long time ago. The peak varied in size by provinces. Most provinces have a relatively low rate of new cases. In fact, as we know, in the Atlantic provinces, we have a kind of multi-provincial bubble, which is interesting, with minimal case count. And in this quieter phase now in the summer, there's been lots of stock taking and fortunately not too much finger pointing, as we've had a gradual reopening of the economy and civil society. Nonetheless, a lot of anxiety about the fall, when Canadians will be moving indoors. We know the virus can spread through fine droplets, a sort of coarse aerosol modality, and that if you have limited ventilation and people together in closed spaces, schools, work sites, and so on, there is a risk. So, you know, it's a funny time in terms of the zeitgeist. Pretty much everyone I've run into feels either slightly depressed or oppressed by what has gone on, and a bit of a sense of a lull before the storm. Let me switch quickly to immunity as an issue here, because I'm not an immunologist, but I do think it's important to understand how your body fights the virus. Immunity basically has 4 components, as I think of it in a very simple-minded way. There's innate immunity. We're all born with some programming to help decide what is ourself, what is an invader, a pathogen. And when that system goes awry, we get autoimmune disease. And on the other hand, adaptive or acquired immunity is a protection that builds throughout our lifetimes as we're exposed to different pathogens or antigens. And that's obviously what we get when we're fighting a virus that comes into play. There's 2 other things, though, in the immunity cascade that are worth thinking about, and one is passive immunity. That's where you actually have received antibodies that may have been pooled from other people who've had a disease and recovered from it. They may be generated artifactually, but in the laboratory or a production facility. And those antibodies can help protect you passively for a period of time against getting a disease. And there are some instances where that's used in medicine today. And then, of course, the ultimate form of protection comes from immunization, which capitalizes on our adaptive immunity. Basically, you say, we'll present you with this antigen. We may present you with an attenuated form of the virus, or we may actually take a fragment of the virus that's relevant to spread, and the body creates an immune response involving both cellular and humeral arms that I'll come back to, and that's how you get protected. Inflammation and infection work together, of course. Many of the responses to infection, as you know, involve inflammation. You'll see that red area around a pimple or a boil or any form of infection inside your body. That inflammatory response can be quite damaging. And this leads to this phenomenon we've seen with both SARS outbreaks, as well as Middle Eastern Respiratory Syndrome, another coronavirus that caused a number of serious outbreaks a few years ago. All three had what are called cytokine storms, where the body's inflammatory response raced out of control and did enormous damage, usually to the lungs, and in many cases causing death from respiratory failure. So a word about adaptive immunity. We all remember learning at some point in school that the immune system responds in two ways. One is the cells. The other is the production, as Paul Lem said, of antibodies, and the latter is the humeral arm of the immune system. Now, the cells come in different types. We're not going to get into all that, but they're vital in a couple of respects. They are effector cells that can attack the microorganism or the virus, but they also can carry memory. And this sometimes gets forgotten that CD4 cells, for example, are T cells that have very strong memory of past infections. On the other hand, humeral immunity, as Dr. Lem said, involves circulating proteins. These are also produced by cells, of course, B cells, that can bind to the virus, make it a target for cells to kill it off. They can also disable the virus by preventing it from interacting with the receptor on a cell that it wants to hijack to reproduce itself at an enormous rate. So these are both important. They work synergistically in helping keep us safe. Let me switch then quickly to the Immunity Task Force and what it involves and what we do. We were really brought into being in part because of a hope that the antibody responses could be measured and would give us insights into the course of the epidemic, and even the possibility of things like immunity passports, where we would find that a large number of people had been infected without knowing it, and that we would have some ability to designate some people as safe to travel or safe to work, and that would help us to manage our economic and social response to the outbreak. In many ways, that was, I think, a bit of a fantasy. It assumed that the outbreak would race far enough through society that many people would be exposed, which would mean many people also getting sick and a substantial number dying. But it also had a bit of an overestimation of how often people were going to be asymptomatic or mildly symptomatic and go undetected. I think we all thought it would be more of a phenomenon than we've seen, certainly in Canada. The last reason it was a bit naive was, of course, the fact that the immune response is complicated, and it's not only about antibodies. So not an idea that had a lot of long-term merit, but it is worth knowing that when you look at it practically speaking, this notion that we would have huge numbers of people who were immune and had had the disease without knowing it turns out to be not entirely true, as I foreshadowed a couple minutes ago. The task force has been involved in supporting people doing these studies across Canada. So far, there's been one cross-Canada study involving 9 provinces. We've also had provincial specific studies done in BC, Alberta, Ontario, and Quebec, about 23,000 tests so far. And basically, the background immunity based on seroprevalence or antibodies seems to vary from well under 1% to slightly above 2%. Now, that's way above the number of people who've actually been infected based on swab tests, the nucleic acid tests that Paul talked about. That number is 120,000, or about 0.3% of the population. So the ratio we're seeing varies by area, ranges from 3 to 7 times higher. So there certainly are people who weren't detected and people who may have had a milder asymptomatic disease who escaped notice. So we can talk perhaps in the question and answer period about why Canada did pretty well on that front. But it does mean that we have to now think hard about the fall because there's a lot of susceptibility. And that leads me back to another point that Paul made about the need for a scalable, affordable, accurate test that can be deployed that is fast. You know, good, fast, cheap, as Paul said, pick any two. But we certainly need some method of testing, not for antibodies, but for the presence of virus, on a repeatable and scalable way in schools and work sites. And there's a quest worldwide for this, including using saliva as an alternative as testing substrate. This is a big focus for work everywhere. To get ahead, we also need to understand the T-cell response, the cellular immunity, which turns out to be, in this virus as in many others, very important. There may be more immunity than we imagine as we start to understand the memory of the virus that exists in T-cells. So that work is being done worldwide, and the task force is supporting similar work in Canada. We need treatments. We really don't have great treatments for this virus so far. It may be anti-inflammatories like steroids that limit lung inflammation. It may be other drugs borrowed from treatment of rheumatoid arthritis and other inflammatory arthritides that prevent inflammation. And it may be antivirals. Right now, remdesivir is being stockpiled by the US government. I must tell you, based on the randomized trials, it's not all that effective. And we'll see how the newest trials come out, but I'm not bullish on remdesivir. However, there are other antivirals being produced. And the one that's very interesting here is monoclonal antibodies. And this takes us back to immunization and that immunity factor that I talked about earlier. Remember that you can have passive immunization, as I said. You can get antibodies not produced by yourself, but taken from people who've recovered from a disease and have been pooled and be given to you if you're ill or if you've been exposed and there's a desire to prevent any possibility of you becoming an infection because of some particular vulnerability. And those monoclonal antibodies, if they're powerful enough, may also be given if someone is acutely ill already with the virus and can help block its action on the body and slow the course of the disease and enable the person to recover. So both modes of use of antibodies are being tested now. The antibodies typically target more than one element on the virus to ensure coverage. They are being produced industrially. They're also being harvested from blood donations, pooled plasma. Both types of passive immunization are being tested in many clinical trials. My own hunch is that the engineered monoclonal antibodies will turn out to be very helpful for this disease and maybe the bridge that we need to a vaccine and give us a bit of a breather as we get through the next few months. And as I wrap up, let me turn to vaccines. I mentioned that as the sort of fourth element in the four-legged table on which immunity is thought about. And that is an area where I have to say I'm very optimistic. We have never had the world move as quickly on vaccines as is happening now. There are studies moving through phases 1 and 2 at a rapid pace, some phase 2 studies completed, showing good safety and excellent immune responses, both humoral and cellular, in large numbers of subjects. Some companies are moving to phase 3 studies, which are really ambitious. These involve typically 30,000 people, comparing those who had the vaccine to those who get a placebo vaccine to see what the risk of infection is and whether people are protected. There are simply so many of these that no one really can quite keep track of how fast they're all moving, although I know the National Vaccine Task Force is tracking all of them. And let me emphasize, there are many different platforms in play here, promising data on safety and efficacy. And my own expectation is we will have multiple vaccines in use starting in the spring of 2021 in this country, which may be unduly optimistic, but I'll put money on that. So vaccines are a topic in themselves for another time, but simply to say that I do remain quite optimistic that vaccines will be critical here, that monoclonal antibodies will help us to manage acute disease when it happens, and that we will return to a much more normal existence before the end of 2021. So I hope that's helpful as an overview, and I'd be happy to take questions. Thank you again, Tim.
Well, thank you very much, David. That very helpful indeed. Your characterization of people's responses as oppressed or feeling oppressed or depressed, I thought was very apt. It's been my experience in conversation with others as well. Your hopefulness about a vaccine will hopefully push back on some of that on both sides. On questions, I'm going to go back to our three panelists in order. I've got questions for several of you. As I said, I'm going to ask one just to kind of kick it off, and then we'll open things up. And I'll ask each of you to answer the question, but then I'll ask the other panelists to weigh in as well. So first, I'll go to Lucy and to Chelsea. The COVID Alert app is very interesting. I will admit that I had not downloaded it and was downloading it, following your instructions, Chelsea. But with it in place, it brings lots of questions to mind about what's kind of going on, how I engage as a citizen out there. Should I still practice physical distancing? To what extent can this replace public health measures? What are the sorts of things I should be thinking about on that front?
Thanks for that. This is Lucy. Definitely this is an extra tool in your toolbox, right? So maintain physical distancing wherever possible. Where you can't, like in any enclosed spaces and, various provinces and territories, and municipalities, it's mandated now, but wear your mask. Whether it's a single-use one or a reusable one that you wash after every time you use it, then make sure that you have that. And the basics still apply. Like, keep washing your hands on a regular basis. Where you can't, make sure that you use hand sanitizer. And we've got on the Health Canada website, on the canada.ca/coronavirus website, there's a handy tool there that's kind of basically to help you make informed decisions about the level of risk that you're willing to take. So it walks you through a few different scenarios and whether we consider them high risk or low risk, just to help guide Canadians in their everyday lives as we all start to go about a slightly different way of living.
Thanks, Lucy. Chelsea, anything you'd add?
I think the only thing I would add is that exposure notification is meant to help you take action before you're symptomatic. So it's just very helpful of like letting you know, like, you may have been exposed, I can take action and hopefully stop the spread. But as Lucy said, like, it's one tool in the toolbox. And it's going to take more than just one app to solve the whole problem.
Right. Paul or David, any comments on the app or the comments of your colleagues there?
I've downloaded it. It makes great sense, and delighted we have it, and also delighted we have that rarity of federal, provincial, territorial collaboration to make it happen. This is a nice thing to see.
Paul?
As someone who's based in Ottawa, it was really nice seeing Shopify, their team jump in and put that together so quickly. It's this homegrown solution, really nice to see.
Yeah, it's very interesting to see the level of cooperation across the public-private sector on this. It's quite remarkable. Paul, I'll turn to you. Thinking about testing, where do you think things are going to go? And I realize there's a certain amount of self-interest here, but you've, I think, very thoroughly presented the variety of testing options that are out there. What do you think is going to happen with testing in the future as we continue to live through the current COVID pandemic?
I'd answer that question in two parts. So first of all, I'd say in the short term, we can see, for example, what's happening in the United States. The government is making a big push to deploy those rapid antigen tests, as well as the lab-based PCR tests and the point-of-care PCR tests. So I think it's going to be all of those together to see more and more testing capacity. And then I think medium to longer term, there's companies like ours, we're trying to break that existing conundrum where you got to pick two of the three, where you have to separate, speed, low cost, and accuracy. So we're aiming to, how can we drive the cost of these nucleic acid tests down to the point of the antigen test? So at that point, you would have fast, cheap, and accurate. And with help from the government of Canada as well as the provincial governments, that's the sort of thing we've been doing, building domestic capacity where we're gearing up to be able to produce, I think it's something like 10 million tests or more a year. And with those economies of scale, we're going to be able to drive the cost of these nucleic acid tests, we think, to the point where it will rival that of these cheap antigen tests. And we think that'll be a big game changer until we get to what Dr. Naylor was saying, things like the better treatments and vaccines.
Lucy and Chelsea or David, any comments on testing?
Yeah, I just wondered if I could jump in and say that there's a big push for repeated tests of modest accuracy. The notion that if you keep doing the test every couple of days, you can get ahead of the virus and pick up pre-symptomatic spread and so on. It's brilliant in theory. In practice, the challenge is first that if you have a lot of false positives, you have to send them over to a lab that would do the nucleic acid amplification test, the PCR, et cetera. So that puts a burden on those facilities that are already stretched a bit, particularly if there's an active outbreak underway. The second problem is that if it keeps happening, you create confusion and you undermine the credibility of the methodology, and then people may not comply. And so that gets tougher. You can only really deploy it in controlled settings, work sites, schools, and so on. So the math here is really good for having a test that you can do repeatedly and affordably, but you've got to be careful that your sensitivity is really good on the first round. Maybe you do an adjustment and then the confirmatory test is still point of care, but has higher specificity to clean up the false positives. But the long and short of it is, unless we get something that has decent performance, these point of care tests are going to be a challenge to roll out. The same with the paper strips and all the other technologies being pressed for wide adoption. Great in theory, the logic works, but we need something that, as Dr. Lem says, is close enough in performance to the gold standard so that we don't get into a lot of confusion about false negatives and false positives. We get there, then widespread testing is going to be a very smart thing to do and can be very helpful.
Lucy and Chelsea, any comment on testing?
Nope, thank you.
Okay. Well, the next question I'll ask, and then I'll go to the audience, is to you, David. You gave us actually I found anyway, a very useful overview of the components of immunity, and you touched on cell-mediated immunity. How does that come into the work of the Immunity Task Force?
Not as much as we'd like, for the simple reason that there's not a scalable test of cell-mediated immunity right now. And certainly talk to colleagues in universities and the NRC about whether that can be created. There are what are called ELISpot tests that are a little more labor intensive. And so we've funded, or in the process of funding, a number of studies that will use measures of cell-mediated immunity as they track people along. And that pivot is certainly important and underway. You see in these vaccine trials, Tim, that the investigators will do antibody tests on pretty much everybody, quite sophisticated antibody tests. But they do much smaller numbers of two other types of tests. One is testing for the specific antibodies that are called neutralizing antibodies that actually attack the virus with greatest effectiveness, because those tests are a bit of a challenge to do as well. And they often only do a small subset of tests for cell-mediated immunity. So we're very interested in the moment at that pivot to understand cell-mediated immunity and how it can be used to evaluate not only background immunity, but vaccines as they get deployed at scale. We need that information.
I'm going to take the liberty of asking you a follow-up on that one. You mentioned we're not as far along as you would like to be on that. Are other countries taking the lead in that area? Is there something we can look to? Is there more cooperation internationally that could help on that front?
Yeah, there's huge cooperation internationally, and I think everyone's chasing every arm of the immune system. Every rabbit hole has got traffic in it, trying to figure out just what immunity means. Some interesting work out of Scandinavia, for example, suggesting that a surprising number of people do have high levels of cell-mediated immunity. Why they have it isn't entirely clear. Some question whether there's cross-reaction with other coronaviruses. So that's there in theory and encouraging. I mean, background immunity is much higher than you'd get by measuring antibodies that tend to be evanescent. The challenge is we don't actually know whether that's protective immunity.
Right.
So as you look at the data worldwide, Both arms of the immune system are being explored. The inflammatory cascade in relation to immunity is a hot area for work, particularly to protect people during infection from cytokine storm and other nasty implications of an imbalance in the immune arms. But I would say this is a moving front, and Canada's in the race. But most importantly, to come back to your core of your question, this is much less a race than a dance. I've never seen so much collaboration across so many countries so openly, and interinstitutional rivalries, even in this country, have vaporized. People are just all pulling together in a really encouraging way. So it's a great story that way, and I think we will crack this nut.
Lucy or Chelsea or Paul, any comments on that last topic?
No, just to kind of build on the idea of the cooperation that we've seen at all levels has just been absolutely amazing and really fulfilling to be in the middle of that. So that's the key takeaway for me generally.
Chelsea or Paul?
I give an example of the incredible collaboration. So one of the ways we were able to get a test to market very quickly is because the CDC published their recipe for their COVID-19 nucleic acid test, including all their validations. And so we were just able to piggyback on that incredible amount of work, which we would have had to do ourselves. So it's just this open sharing is making things go much faster.
I do on that front, I do have a thing to add. Like, we build all COVID Alert in the open on an open source GitHub repo, and other versions of the similar exposure notification app were built on open source repos from Italy, from Ireland, from Germany, and we were able to share information with those countries and discover, are there foundational bugs that we can all fix together? Are there, what are we learning? So there's been a lot of wonderful international collaboration on creating these apps, and it's just been really nice to see. And it's nice that what we're doing can be used by, there's a lot of states in the US that are starting to build these apps that are talking to us, asking us how we set things up. So it's been great to see.
If I can just jump in, Tim, going back, the ventilators were another amazing example of collaboration where blueprints for very simple ventilators were on the web, were scooped up, modified, and put into play all around the world. Art McDonald, and Nobel laureate in physics, was closely involved with a group of people from various engineering and physics backgrounds who worked on this for Canada. But Joe Fisher and his group in Toronto got huge numbers of orders for their very small and effective ventilator that had languished without much attention in the marketplace. So it's been a very exciting time for open science, open engineering, and sharing. And last, I would say, although there's always jurisdictional jousting in this dysfunctional federation of ours, there's been less of that than one would ever expect on most issues of this magnitude. And I've been encouraged by the federal, provincial, territorial cooperation.
On the point about cooperation, be it across Canada or around the world, that I think is particularly exciting is, and I don't want to bring more black clouds into a conversation about a black cloud that's a pandemic, but as I'm sure many of you have, I've been reading a lot of history of pandemics, and they're rather regular appearances actually in human history. And the level of cooperation that's occurring now not only bodes well to address the current one, but the long term, I think, which is very exciting. Look, with that, I'm going to ask David McConkey, who introduced us at the very beginning and is my director of, sorry, David, not for introducing you, my director of safety, security, and of operation safety and cybersecurity, and helps with the work of our health and safety committee, to give us some of the questions that are coming from the floor. David, do you want to pose one to one or all of the panelists?
Absolutely. Thanks a lot, Tim. And certainly thanks to all the presenters. I'll just relay a few of the questions. And folks, just again, a reminder, you're welcome to type in questions through the question feature in GoToWebinar. So we've got a few here. So I'll just read them off. I've seen mixed messages about how long immunity persists after recovering from COVID, symptomatic or asymptomatic. What's the latest on that? And the questions are open to everyone unless there's a specific designation.
So I'll open it up to any of you.
I can take that. Oops, I've lost my connection here.
Oh, we got you.
Got me? Okay, I can't see anything. Probably just as well. See if I can get it back. Nope, not coming back. I would just say on that topic, there we are, that the mixed messages are a result of a very fast moving front of science, which kind of goes like this. First, we thought everyone would have antibodies and they would last a while. It turns out that some people do not produce much of an antibody response, and that the antibodies in many instances wane, and that the presence of neutralizing antibodies, which are very important hallmarks of immunity, is also variable. And then we had the cell-mediated story come in suggesting that, as occurred with the two other major coronaviruses that cause substantial epidemics, that there is in fact likely to be a reasonable immune response arising from the memory in those T memory cells that have specific responses baked into them that should enable an active degree of protection against reinfection with the virus. So it's still a moving front. One thing that I think people keep forgetting and that I find reassuring is that although the antibody titers wane and although we are uncertain about the importance of the memory cells, when you look at the world literature, I have not personally seen a compelling account of reinfection. Not one. I've seen media reports that look shaky. Some of them involve people who are immunocompromised who may be shedding virus for a prolonged period. We saw a big scare in Korea where it looked like reinfection was happening. It turned out to be shedding viral fragments that were not infective. And we do know some people do continue to shed fragments for a long time or neutralize virus. But, you know, we've currently got a group of talented graduate students who have set up a Sero Tracker as a worldwide tracking website, distributed group of Canadian expats and at home who are doing this work with us, and they are scouring the literature to see if this is indeed the case. But you know, I've been scouring pretty regularly. All that to me says that if reinfection is commonplace, we sure as heck aren't seeing it. So I actually personally think that's circumstantial but encouraging evidence to suggest there is some degree of durable immunity for pretty much everyone who's been exposed to the virus. Would I take it to the bank if I'd had it? No. Would I behave differently if I had antibodies, even if some of them were neutralizing? I might feel a little happier. I would not lose my hand sanitizer. I'd remain happier. I downloaded that great app. I would still keep my distance. I would wear a mask as I do frequently, and nothing would change.
Does that information reinforce the positive news out of Scandinavia, do you think, David, or not? Or is that a stretch?
I think it probably connects to that, but it certainly, you know, is consistent with what we found with SARS and #1 and MERS, where even as the antibody titers waned, and they seem to wane a little more slowly than with this one, but they waned. Even when they were gone, you could still show the memory cells were programmed to respond. So I'm, as I said, it's circumstantial. We should all remain cautious. I don't care if you've been infected and have antibodies or not. This is still a live question, but I think the circumstantial evidence is encouraging, and it's really encouraging if you think about vaccination. You know, you may need a booster. In many of these vaccines, you may need a couple of booster shots initially, and maybe you'll need an annual booster. It may be that we have to adjust the vaccines annually, but I actually think all of that bodes well for the long-term efficacy and utility of a vaccination campaign. So
Right.
you'll picked up a thread here, and that is that I'm optimistic about how this is going to unfold and end, but I do think it's going to be a tough fall, and we all have to be very careful and prudent.
Paul or Lucy or Chelsea, anything to add?
No, thank you.
No? Okay. David, another question?
Yep, there's a few questions that I've got left over here. So the next question, I'll kind of lump these together, is relative to the app. The question is how it works in conjunction with the Alberta app. And I'll just add a few components to that question around, currently it's available in French and English. Are there plans for other languages? And then in tandem with the question about Alberta, what about the other provinces? What's the timeline for rolling out the app in the other provinces? Thank you.
So that's obviously to you, Chelsea and Lucy.
Thank you. So the first question, is it compatible with AB Trace? It is not compatible. It is slightly different technology. AB Trace also works on the type of technology that was used in the UK, where you have to have the phone open to actually interact. And there are is it just a different kind of threshold of privacy. With the exposure notification framework that we went with, it is a higher threshold of privacy, which is why we went the way that we did. Though if you see in the news, Alberta has now opted to join into this national exposure notification framework with us, which is great. So we're looking forward to seeing them on board. In terms of rolling it to the other 12 provinces and territories, we are very busy working on that, getting everyone onboarded. I can't reveal everything because not everything is signed, but I would say look to the east first, and then we'll see it rolling out. But we hope to have everybody on board very soon. And I think there was a third question, which I have forgotten. I'm very sorry.
Alberta
Yep.
Languages? Did you?
Languages, yes. So it's currently available in French and English. We would love to have it available in more languages that are spoken in Canada. It's just a question of capacity for the team. It is not a question of translating or localizing the app once. Apps update, there's always improvements being made. So it's a question of having commitment from, having a translator or a localizer from those languages coming with us for the whole ride. So it is in our backlog, as we say. It is one of the things we would love to do, but I don't have a timeline for you on it right now, but we would love to do that.
Okay, good, thank you. David, next question.
So the next question, what fraction of the population will have to be vaccinated to secure population protection?
Maybe I'll direct that one, I guess, to you, David. Does that make sense? Maybe Paul, you might have some thoughts on this one too.
Yeah, so it's an educated guess, Tim, and I think, given the R0 value, the exponent of infection that you've seen with this virus, if you just said it was uniform and you'd sort of say 50–70%, this is not measles where you've got to have much higher coverage. But the thing that I find intriguing is not just this interesting question of cross immunity that may already exist, but the fact that the virus, not unlike the first SARS, has been associated with, if not super spreader events, a concentration of outbreaks. It's not as though everyone who's infected seems to be equally infectious, nor is it the case that everyone seems to be equally susceptible. And that lumpiness means that if you were, to try to imagine what the R0 is in reality, so instead of taking the RT, which is the exponent of growth of infection in real time, you think of it localized to a greater extent, and you begin to see a heterogeneity of infectious pattern that is quite unusual, so much so that some modelers at Simon Fraser proposed that the R should be event specific. There should be an event R associated with each outbreak, which is really interesting. If that's the case, if it is quite lumpy in a sense, then you may not need the same degree of herd immunity, so-called, to be attained to slow this down. And it may mean that you will still have occasional flare-ups, but they will be few in number and can be managed. So that's another piece of intriguing news. I'd love to see what some of the, these brilliant mathematical epidemiologists and infectious disease modelers have to say, but my read is that they're starting to migrate towards a view that we may not need to go as high as would be expected on the basis of a uniform infectious pattern, that this is a pretty lumpy one.
Paul, anything you'd add there, or other panelists?
I agree with Dr. Naylor. I think what Dr. Naylor was saying earlier is the science is so open. It's almost every week, every few weeks, every month, there's new discoveries. And I think it's going to be hard to say. If I had to guess, we're going to have to find out what happens in reality and adjust from there.
Right. Chelsea, Lucy? David? Next question.
Next question, I think relates a little bit to what was said there. Will a potential vaccine end up looking like an annual optional seasonal flu vaccine, or more like the series of legally required vaccines, for example, for kids entering into school, MMR, diphtheria, and all of that kind of thing?
Yeah, I actually can't predict that. At present, the things are moving, as Paul said, at such a pace that it would be hard to call it. The virus is certainly mutated, but I would say less than many feared. And so we all know that the likely target is going to be the spike, where the coronavirus attaches to the ACE2 receptor on cells and multiple body systems, which is why you see this multi-system long hauler phenomenon. So it's not clear to me how much mutation can change that. The same with the monoclonal antibodies. They often have a couple of targets. They don't just hit the spike, they hit something else. But depending upon the vaccine, it may be that some of these vaccines may be quite definitive protection for some period of time. I think we have to just wait and see. The final thing I'd say on this is the virus sort of sets the timetable for things. It sets an agenda that's for research that has turned out to be way more complicated than many people thought, and it will set a timetable for what vaccines work and how often we need to give them and how often we need to change them.
So I'm going to provoke a little bit on that point, David, because your last phrase caught my attention. The virus sets the timetable, and the question I have is it setting the timetable because there are so many unknowns and we've decided we just can't deal with those unknowns, or is it setting the timetable because and again, I'm being provocative, but there's an unwillingness to say, all right, this is a reality, it's something we're going to have to deal with, but the rest of society has to get on as well. We have to manage the whole host of other things. And I look at things like the app, and I look at things like the testing work that Paul and his company and other companies are doing, and I see those things as helping to kind of push us back into the regular day-to-day of our lives. Whereas when we talk about the virus setting the agenda, it pulls us back from the day-to-day, and that's a conflict that I think we're all having to deal with, and it goes to your depressed assessment of people at the beginning. Are we striking the right balance?
So just to be clear, I was asked about the vaccination timetable and whether or not we would need annual vaccines or not. So my reference to timetable was pretty narrow, and that was about mutation rates and durability of protection. So
Yeah.
you're now going into another zone where I think other people will have opinions, and so let's hear what Chelsea and Lucy and Paul say about whether we've got the right balance, and then I'll weigh in. I've already said enough.
Well, I'll open the floor to others. Paul, I'll go to you first. I don't want to put our friends who are federal government employees on the spot here to comment on a public policy question. So maybe I'll go to you.
Thanks for bringing on the hot seat. One of the ways I like thinking about this is, we have friends, we have families, we have parents, and we're seeing it's the more elderly people who are more affected. I mean, I have my two elderly parents. One of my parents is immunocompromised. I personally am grateful that society is taking the efforts it's doing. Like, some people I know are arguing that we've gone too far, that we're shutting down our economy. I like the idea that we are trying to protect the most, some of the most vulnerable sections of our population, and that I don't think it's going to go on because Dr. Naylor said, and as you pointed out, Tim, we have technology solutions that are coming on board. We have biotech solutions, vaccines, they're all coming on board. I like the idea, though, that for this period of months, we've taken our time, we're trying to safeguard our population and let these more technical solutions come on board.
Good answer. Good answer. I won't put our friends Lucy and Chelsea on the spot with that one. I'll just leave you all to reflect on that as we get more questions. David McConkey, do we have another question from the floor?
Yeah, we've got a couple more questions. And again, I'll invite others as we're going through the discussion here to see if there's anything you'd like to ask. One question that's relating to the app, but is obviously a broader question around the 15-minute exposure timeline. Wondering if folks can comment on the reason for that amount of time.
Yeah, so this is a guide, kind of like we're going with, okay, let's start over. So the technology that we're using is new. As we all know, the way we're dealing with the virus is new. And as Dr. Naylor and Dr. Lem were saying, we're getting new data every week and new information. So the 15 minutes for 2 meters or less is based on the current recommendations that we're getting from the people who are consulting with us on health. We have a couple of excellent people from PHAC, which I can't remember what it stands for again, the Public Health Agency of Canada, who are helping us. Thank you, I got it. Who are helping us determine how we might change that distance and time as we get more data about how the virus is transmitted. We will absolutely tweak that based on the medical guidance we are given, because we are not the doctors, we are the technology builders. So we are looking to that community to help us guide. But that is our currently what we're doing based on the information we were given from PHAC and other medical professionals.
Thanks, Chelsea. Lucy, anything you add there?
Just, yeah, like we've been modifying our approaches and the advice that we've been giving as we've learned more and more about the virus, how it's transmitted, how it acts. And so, the app might change as we continue to learn about the virus and as we gain more understanding. So at the moment, the 15 minutes is what makes sense. Might make sense to have a different timeline some other time, right? So we'll keep evolving as our knowledge keeps evolving.
Right. Okay. Just a follow-up on the app and that 15-minute point, actually. Have you faced much criticism on the privacy implications of it? Chelsea, you were very careful in how you spoke to those very clearly. As I say, I was downloading it, I was walking through it with you, and of course I got that Bluetooth notice. Has that been much of a concern expressed by the people you're dealing with as you develop this?
Generally, it has been pretty good. And part of what we did was we started building it in the open from the start. So people who are curious about the code, people who are wondering what it does, they can always, as we were building it, they could watch as we built, follow along as we built it. And then we worked very closely with the Office of the Privacy Commissioner, federally and provincially, to make sure they understood what we were doing and what durations, like code exchanges, what all that meant, so that they could feel confident in recommending or not recommending the app. In both cases, they very much recommended it. We've had the Canadian Civil Liberties Association having, I'm definitely downloading this app. I'm kind of on the fence. Michael Geist, you know, a lot of people who were hoping would be supportive of it, because we built it privacy first. We know that people aren't going to want to have to sacrifice their privacy to stay safe.
Right.
So that actually that's been very positive feedback so far.
Yeah, yeah.
And the thing that I'd add there is that both on the federal side, so we had the Office of the Privacy Commissioner review. We worked with them back and forth for several weeks as we were developing the app to get their input, to make sure that it was something that not only addressed potential concerns, but like exceeded in terms of response. And on the Ontario side as well, the Ontario Privacy Commissioner reviewed the app on their side as well. And they were also very supportive. So I think that we've been able to, because of that approach, because of that collaboration and addressing any potential issues off the top, it's been very beneficial in terms of making sure that there are no issues that haven't been thought through as we've developed the app.
Right. And a follow-up on that, have you worked through any kind of strategy in terms of working with other sectors to help advertise it? And look, we're giving a bit of an advertisement right here, and we're happy to do so. Are you thinking about partnerships with various corporate sectors and so on to help advertise the app?
Yes, absolutely. So what we've been doing is it started off even with Apple and Google. So the app of the day when we launched,
I'm losing you there. We may have lost her.
Yeah. I can jump into a bit, though. This is definitely Lucy's domain.
Can you hear me now?
Yes, you can. Go.
Okay. So in addition to that, we've been talking to different councils and associations across the country. We've been in discussions with, the fine folks at Shoppers and Loblaws and Starbucks and Tim Hortons, just so that if we didn't get you through radio advertising and social media, then we're getting you as you're either going into a store or there's a pop-up in somebody else's app, like let's say for the Optimum services and whatnot. We also did reach out through all of the telcos. So you may have received on your cell phones messages from your provider, so whether that was TELUS or Bell or Rogers or others. And so they were targeted for folks with Ontario area codes, but encouraging people to download. So we've really done a full court press in terms of how we're reaching out to people and doing so in as creative a fashion as we can.
Yeah, very interesting. I'll go back to David McConkey. Another question, David?
Yeah, so a very general question that probably to a certain degree we've touched on, but I think clearly written and probably exemplifies a lot of what many Canadians are thinking about. Will we ever be able to consider COVID-19 to have been eradicated? And the comparison is with smallpox in 1979. Will we ever expect to be in that kind of a situation?
I think, Dr. Naylor, I'm going to put you on the spot first again on this one.
Yep. So the short answer is I don't know. Again, so much depends upon mutation rates and how effective any vaccine is. And I expect there will be multiple vaccines in place, so we may find that some subset of them are particularly effective and durable. If we get there, yes, it's possible. I would personally, hearken back to SARS-CoV-1, which basically disappeared. Everyone talks about these as triumphs of public health and containment and so on. I would tell you that it's sometimes a bit mysterious why viruses abate and what exactly happens. In that case, mutation was part of it. Some strains were less infectious. So long and short, can't tell, not particularly focused on complete elimination. really focused, coming back to timetable, on getting control and effective treatments that minimize the damaging effects of the virus when people are infected, and let's get civil society and the economy going again.
Any other comments on that one, Paul?
Tim, what I would add is what you were saying, how in the history of humanity, every 50 to 100 years, there's some sort of pandemic, like the Spanish flu of 1918. And we see, as Dr. Naylor was saying, there was SARS, there was MERS, now there's SARS-CoV-2, which is COVID-19. It may be that we can eliminate COVID-19. If I had to predict, there's going to be some other respiratory virus that comes out after that. And what I feel optimistic about is we are now building that infrastructure, that scientific body of evidence. So when the next respiratory virus comes, we will have that disseminated DNA analyzers. We will have immune research where people have an idea of, we don't have to start from scratch. We will have vaccine companies that already have their bioreactors, develop that infrastructure. So hopefully the next time around, we can respond much faster, and then we won't have the same hit to our economy.
Can I just jump in?
Go ahead, David, sorry.
I was just going to say, the other thing that I'm encouraged by is not only has the scientific community pivoted, but private-public partnerships have been strong to help respond. And I really hope we spend some time and energy as this recedes, building up a made-in-Canada biotech capacity. We have this excellent health research substrate in the country. It's very competitive globally. We've not invested in and supported Canadian companies in that sphere. Venture capital's building up a little bit, is still pretty thin in that direction. And if you think about how much better off and smoother this might have been if we'd had a stronger production capacity, had not just Dr. Lem's company, but a range of competitors in that space that all had good legs. This would have been a different feel. We were at the mercy of many international providers. Tremendous work done by Procurement Canada, Health Canada, to get us the supplies we needed and support provinces and territories. But it was a scramble, and I hope next time we plan better, we use the capacity we build up, we don't lose it, and we also build a private sector that is going to give us a lot more self-sufficiency on all these fronts.
Excellent comment. Lucy or Chelsea, anything to add on that one? Okay. David, back to you. McConkey.
So this one of the last questions here, within the statistics of COVID-19 deaths, what proportion are directly related to COVID-19 complications? And I suppose that question is about perhaps the cytostorm, situation, versus what proportion could we say are more directly related to underlying health conditions? In other words, is a death count really an accurate picture of the severity of the disease if that distinction is not made?
It's the dying of versus dying with.
Yeah, so let me just say that this has become a favorite trope of the minimizers, and it troubles me. We have all kinds of statistics on flu that have some of the same issues, and you'll see people inventing arguments for and against which of these organisms has the bigger toll. Is in fact this, just another form of flu in terms of its total society impact. And I think if you don't want to count deaths, count ICU admissions. Any of us who practice can tell you, in a bad flu season, you don't see the kind of rapid flooding of ICUs we saw with this disease. And the other thing I'd say is that if you're going to get into with versus from, then you have a problem with every other death certificate.
Right.
In that many people die with multiple comorbid conditions. I filled out death certificates. I pronounce people dead. It's often a guess as to where you're going to ascribe a cause of death. So I do think that this argument is One that I understand, and we all fuss about it scientifically, particularly epidemiologists fuss about counting deaths accurately. But all I can tell you is look at the hospitalizations if you don't want to look at the deaths. Look at the disruption, and then look at the long haulers we're seeing. And I'm certain, again, we're going to see a whole bunch of people minimizing and saying they're all psychosomatic. When you think about how many ACE2 receptors there are in every system of the body, and the fact that this virus can attack any and all of them, I would challenge anyone to simply dismiss all of these individuals turning up with long-term symptoms and to say it's all psychosomatic. I strongly doubt that. We need to investigate those long haulers and try to figure out how to treat them and help them. So the long and short of it is, worthy issue of debate, great question, lots of tough rhetoric as you get into that zone, particularly in the US, it's such a hot debate. And my long and short of it is, if you don't want to count bodies, count ICU admissions, count long haulers, look at how sick people have been with this condition. And I think I'm back to where Dr. Lem was saying, I think we have dealt with this prudently and effectively in Canada. It could have been better. It could have been a lot worse. I give the credit to Canadians who complied brilliantly here. This is, an amazing example when you look at the amount of community spread. We concentrated our deaths tragically in long-term care facilities. The actual number of deaths outside of those terrible concentrations was pretty modest. And so far from seeing that as grounds for minimizing it, I see it as grounds for taking some pride in how we conducted ourselves and for continued prudence.
Well, look, we're almost at the end. I was going to ask each of you for any concluding comments you might have, and I'll go in the order of speakers again. Lucy or Chelsea, anything you'd like to say by way of wrap up?
Thank you very much for the opportunity to come and speak with you.
Well, thank you very much. Dr. Lem.
I think what Dr. Naylor was saying is this is an incredible opportunity for Canada's biotech and R&D communities, where I think we're seeing it's very important to have that domestic capability. And I know Dr. Naylor was president of U of T when I was there during my residency, and I know he always tried to push forward Canadian R&D. I think we've always lagged behind commercializing our R&D, and hopefully this is a time where we can finally realize the potential of what we've been building in Canada for decades.
Thank you. Hear, hear. And Dr. Naylor, any final remarks on your side?
Just that I hope everyone can stay optimistic and endure. It ain't over. We got a little ways to go, but I do think there's a lot of light at the end of the tunnel.
Well, look, I want to thank all of you. I'll just ask David McConkey. Anything else by way of wrap up, David?
Thanks a lot, Tim. No, just on behalf of the CGA members, specifically also the Health and Safety Committee, thank you very much for your contribution today, obviously, but more broadly in the work that you're doing, the critical work that you're doing. And thank you very much on behalf of the industry.
Yeah, I'll just underscore David's remarks. I've got a daughter playing piano upstairs. That's the background music we're using for wrap up here, not by design, but in the COVID environment, we all are confined to homes or restricted office access, and it has forced us to reflect on all sorts of things much more carefully than we might have otherwise, and we very much appreciate your help with us reflecting on things here today. Thank you all for your work. You've touched on various dimensions of this pandemic and various dimensions of the Canadian response. And to underscore Dr. Naylor, your points, I think there are lots of reasons to feel proud as Canadians. Peace, order, and good government is written into our Constitution. I think we've demonstrated that in our response on this. Dr. Lem, as you note, the more we can do to promote companies like yours and the kind of work you're doing, the more creativity we can promote in science and the successful use of new technologies, the better we can deal with these kinds of crises. And to Chelsea and Lucy, thank you very much. I think the app's fascinating, and it's a sort of excellent example of private public sector cooperation that can help us deal with these kinds of crises. So With that, I want to thank you all again, and I want to thank our audience for joining us today. We hope to be doing more webinars over time as CGA that are of broader public interest like this, and we thank you for taking the time to take part in this first one. This has been recorded, and so I hope I'm not speaking out of turn by saying that we could make parts or all of this recording available. I note that there were several comments about presentation materials, so we'll endeavor to make some of that available. So once again, thank you all for joining us, and have a good rest of your day.
Thank you for the opportunity. Bye-bye.
Bye.